USMLE style question on spinal muscular atrophy. A 6-month-old boy is brought to the pediatric clinic for evaluation of delayed motor milestones. His parents report that he has been unable to sit or roll over, and he has shown generalized muscle weakness. On physical examination, the infant exhibits hypotonia and fasciculations of the tongue. There is absence of deep tendon reflexes in the lower limbs. Genetic testing reveals a mutation in the SMN1 gene, leading to defective snRNP assembly. Which of the following is the most likely diagnosis? A. Duchenne muscular dystrophy. B. Spinal muscular atrophy. C. Amyotrophic lateral sclerosis. D. Charcot-Marie-Tooth disease. E. Myasthenia gravis. Answer: spinal muscular atrophy. Explanation: this infant's presentation is most consistent with spinal muscular atrophy, SMA, a congenital disorder characterized by degeneration of the anterior horn cells of the spinal cord. The key features supporting SMA in this case are clinical presentation: hypotonia, floppiness, which is typical of lower motor neuron LMN lesions; muscle weakness and fasciculations, especially of the tongue, indicative of LMN damage; absence of deep tendon reflexes due to LMN dysfunction. Genetic cause: SMA is caused by a mutation in the SMN1 gene, which encodes the survival motor neuron, SMN protein. This protein is essential for the assembly of snRNPs, small nuclear ribonucleoproteins, and the maintenance of motor neurons. The SMN1 mutation leads to defective snRNP assembly, resulting in LMN apoptosis and progressive muscle weakness. Pathophysiology: in SMA, anterior horn cells, LMNs, undergo apoptosis due to the inability to produce sufficient SMN protein, which is essential for motor neuron survival and function. This degeneration leads to progressive muscle weakness and atrophy in affected individuals, particularly those with type 1 SMA, the most severe form, also called Werdnig-Hoffmann disease, which presents in infancy. Why not the other options? A. Duchenne muscular dystrophy. Duchenne muscular dystrophy, DMD, is caused by X-linked mutations in the dystrophin gene, leading to progressive muscle weakness and cardiomyopathy. It typically presents with proximal muscle weakness and elevated creatine kinase, CK, not fasciculations or LMN signs. C. Amyotrophic lateral sclerosis, ALS. ALS is a degenerative disorder of both upper and lower motor neurons in adults, not in infants. It causes both UMN and LMN signs, including spasticity, UMN, and muscle weakness, LMN. The infantile onset of SMA distinguishes it from ALS. D. Charcot-Marie-Tooth disease. Charcot-Marie-Tooth disease is a peripheral neuropathy that presents with distal muscle weakness and sensory loss in the feet and legs. It is typically progressive and would not present with hypotonia or fasciculations in infancy. E. Myasthenia gravis. Myasthenia gravis is an autoimmune disorder that causes fatigable muscle weakness due to antibodies against the acetylcholine receptor at the neuromuscular junction. It typically affects adults, and the presentation in infants would be rare. The fasciculations and hypotonia are more consistent with LMN damage as seen in SMA. Take-home point: spinal muscular atrophy, SMA, is a congenital motor neuron disease caused by mutations in the SMN1 gene, leading to the degeneration of anterior horn cells and progressive weakness due to defective snRNP assembly and LMN apoptosis.